Good afternoon, everyone. We are from Ruminant Station Group. Today, we are going to present our case, bovine respiratory disease in calf. It is our member, including Supakon, Pradon, Non, Jetawat, Jirawat, and Nontakon. It is our advisors, Ajahn Shavalit, Ajahn Banlu, Ajahn Jikamon, Ajahn Susaichai, Ajahn Shravut, and Ajahn Akrapong. This is outline of our presentation. Let's start with history. This calf name 64037. His age is 10 days and he is mixed breed of Holstein Friesian. His body weight is about 25 kilograms. The calf was assigned to the research project to be the control group. 10 days ago, after he received at the faculty, many calves had shown clinical signs of illness. The calf was fed by milk replacer and lived in evaporative cooling system, each caged individually. The chief complaint is decreased appetite, depressing, panting, and lateral recumbency. The physical examination shows depression, low body condition score, dehydration, prolonged CRT, tachypnea, and dyspnea. There was increased lung sound with bronchi at left cranial lung lobe. This is his illness history. At 1 p.m., he received aceta-5 and his blood was collected. At 1:17 p.m., his pulse was deficit. He had pelvic membrane and shock, so CPR was performed. At 1:22 p.m., he was cyanosis and had cardiac and pulmonary arrest. Then he was shocked again. Adrenaline was administered intravascular. Unfortunately, he died after that 5 minutes. Next is blood profile. The complete blood count shows polycythemia and low MCV, and monocytosis, neutropenia with a degenerative left shift, and lymphopenia. The blood chemistry review high fibrinogen, high ALT, and low creatinine. After he died, necropsy was performed. In with external examination, there was fecal stain around the anus, indicating this calf had diarrhea. In thoracic cavity, there was no negative pressure. Inside the thoracic cavity, 5 minutes of purulent pleural effusion was found, and pleural fluid was analyzed. The pleural effusions are white and cloudy. The total protein was 6.2 grams per deciliter and specific gravity is 1.027. The total nucleated cell count cannot be performed because high stability and high cell degeneration. The pleural fluid contains degenerative mononuclear cells and numerous cocci bacteria. Next is lung. There were fibrinopleural pruritus at left cranial lung lobe, and pericardial also found fibrinous pericarditis. At left cranial lobe, there was purulent bronchopneumonia. The lung biopsy was performed. The visceral and peripheral layers of the pleura is covered by a thick layer of fibrin accumulation, which show in green arrow. There was infiltration of degenerated polymorphonuclear cells, which show in yellow red arrow. At alveolar space, it was filled up with toxic polymorphonuclear cells and macrophage, which show in yellow arrow. There are multifocal clusters of rod-shaped bacteria found in pleural layers as well. The gram stain of lung parenchyma and visceral pleura reveal that There were numerous of gram-negative coccobacilli-shaped bacteria. Inside the heart chamber, there was no remarkable lesion, and the heart biopsy was performed. From the parenchyma layers, the irregular eosinophilic fibrin was deposited.
Next, liver. There was no remarkable lesion, and the other organs such as brain, kidney, or brain, there were no remarkable lesion too. Next topic is bacterial culture and susceptibility test. From the bacterial culture result, we found coagulase negative Staphylococcus or CNS and E. coli. This slide shows susceptibility test of coagulase negative Staphylococcus or CNS. You can see that the CNS is resistant to many antibiotic drugs, including ampicillin, cloxacillin, norfloxacin, enrofloxacin, marbofloxacin, tetracycline, oxytetracycline, azithromycin, erythromycin, clindamycin, and gentamicin. While the E. coli is resistant to fluoroquinolone groups, including norfloxacin, ciprofloxacin, enrofloxacin, marbofloxacin, but both of them are susceptible for amoxicillin clavulanic acid, ceftriaxone, sulfamethoxazone trimethoprim, and amikacin. For the diagnosis, this type had bacterial bronchopneumonia with severe fibrinopurulent pruritus and pericarditis, which leads us to suspect bovine respiratory disease complex.
And next, for the discussion, we will start about the bovine respiratory disease complex. Bovine respiratory disease complex, or BRDC, is a multifactorial etiology and developed as a result of complex interaction between environmental factor, host factor, and pathogen. It starts with the environmental factor like transport stress or crowding, serve as a stressor that adversely affect the immune and non-immune defense mechanism of the host. In addition, some of the environmental factors, like inadequate ventilation, can enhance the transmission of infectious agents among animals. Many infectious agents have been associated with BRDC. Next is ensutic pneumonia in calf or the calf pneumonia. It's a problem in the calf that age less than 6 months old. It's more common in dairy than beef calves and more common in house dairy calf than in those raised outside the house. The etiology of the disease is similar to the BRDC, but this disease is occur in calves. The pathogenesis involves environmental and management stressor and possibly initial respiratory viral infection, followed by the secondary bacterial infection of the lower respiratory tract. While host factor like failure or passive transfer is also risk factor for the disease to occur. This picture will show you about how the BRDC affect the animal. Start with the state that will affect the upper respiratory tract defense mechanism like a mucociliary system, and the virus damage the upper respiratory tract that can induce the bacteria to the lower respiratory tract and can cause the bacterial pneumonia. Next is a viral respiratory tract infection in the cattle. We have 4 main diseases that can affect the respiratory tract of the animal. First is parainfluenza 3 virus, bovine respiratory syncytial virus, bovine herpesvirus type 1, and bovine viral diarrhea virus. And next is a bacterial pneumonia in cattle. The three main bacteria that can find in the pneumonia in cattle is a Mannheimia hemolytica, Pasteurella motorcida, and Mycoplasma bovis. We will start with the Mannheimia hemolytica. Mannheimia hemolytica is a more frequent isolate from the lung of cattle with BRDC, but less frequently cultured. Normally, this bacteria is in the upper respiratory tract of the cattle, but when it's called a disease, inhalation of and colonization of the lung may occur because of suppression of the whole defense mechanism that relate to the environmental stressor or viral infection. The lesion is usually severe acute hemorrhagic fibrinonephrotic bronchopneumonia that you can see in the next picture. Next bacteria is Pasteurella motorcida. It's the important cause of bacterial pneumonia, but pathogenesis of pneumonia is poorly understood. Normally, this bacteria is in the upper respiratory tract like a Mannheimia hemolytica, and the lesion of this disease is usually purulent bronchopneumonia with less fulminating fibrous to fibrinopurulent bronchopneumonia that you can see in the next picture. And the last one is a Mycoplasma bovis. It's a cause of respiratory tract and arthritis in fat-lock cattle and in young dairy and rear calves. Usually, it has a mild side of respiratory disease, but the virulent strain can cause severe disease. So, and the lesion, usually the chronic bronchopneumonia with caseous and coagulative necrosis. You can see the next picture. And prevention of this disease, the prevention program begin with the vaccinating the cow against specific respiratory virus and bacteria at 3 or 4 weeks pre-partum to improve the quality of colostrum antibody. The calf should receive good quality colostrum at 8 to 10% of body weight in the first 6 hours after birth. Newborn dairy calves should be housed individually in hutch or stalls. Fed whole milk or high quality milk replacer with the fiber content less than 0.25% until 8 to 12 weeks old. And calves should be similar age with assembled in the group and should vaccinate before grouping. For the control program, we usually 3 methods: improve husbandry, proper housing, and adequate ventilation. And the treatment of the respiratory disease is usually we recommend the use of long-acting antimicrobial like tulartomycin, tumicocin, furfinicol, elofloxacin, and ceftiofur. Use NSAIDs to control the fever, like the fluoxetine mecumin, bronchodilator like a clenbuterol to treat the bronchoconstriction. Antihistamine and mucolytic drug can use to suppress the mucus and treat the cough. Corticosteroid like dexamethasone can help in the respiratory inflammation and the bronchoconstriction, and supportive treatment like fluid. So this is our acknowledgement to our professor. And thank you. Do you have any question you can ask right now?